Yeah, just want to make sure the recording was on. So we're going to explore our case together today. And so this is the history for the case. A 55-year-old man was found unconscious on the floor of his bathroom one evening by his wife. He's rushed to the A&E department of the nearest hospital where he's pronounced dead. His wife gives a history that he was diagnosed with diabetes mellitus some years previously, has been taking tablets daily, but there's no other significant medical history. He had not complained of feeling unwell prior to his collapse. And of course, an autopsy was requested. So, having heard that history, what kind of case is this? What kind of autopsy case would this be? Young people, what kind of autopsy case is this? Think about it. He has a history of diabetes, but hasn't been complaining of any illness. And his wife finds him unconscious on the floor of the bathroom. So it is a coroner's case on the basis of, okay, I see somebody offering a suggestion of on the basis of sudden death. And yes, so that would be one possibility here. But certainly it's a coroner's case because the patient has died suddenly, and we don't have any indication from the history, for example, that he had been seen by a medical practitioner in the previous days with any sort of significant diagnosis. So certainly an important consideration is that this is a case of sudden natural death. And if you think about it, um, the clinical doctors would not be able to write a death certificate in this patient. They would have no no idea what's really happening. So sudden natural death is one possibility in terms of the type of causation for this case. So what I want you to do now is spend a few minutes and think about, based on your vast knowledge of pathology, um, what could be some possible causes of death in this patient in terms of specific pathological diagnoses. And that's an important, no, I don't want you to, don't put it into the chat yet. I want you to take the time for a minute or two. No, I would say I'm going to give you at least 5 minutes here. Take your time and think through and make your little list, and then I'll invite you to share your considerations in the chat. What is important? Sure why I'm having the feedback. Okay. Notice we talk about pathological causes, okay? So I want to make that distinction for you. Patients will have things like seizures, or what's another common one you all will come with? Arrhythmias. Those are clinical findings. Whether it's arrhythmias or epilepsy or seizures, there is something, there is a pathologic cause that would be underlying that, whether it's in the heart or the brain or so on. And that is what I want you to be working out in your mind. What could be the pathology, the pathological cause of death in this patient? So for those who are joining, we have this little scenario: a middle-aged man found unconscious on the floor of the bathroom known to be diabetic, but no other significant history. We have agreed that this case is a coroner's case. And so I want you to take a few minutes now and work through in your mind. I'm not even going to stress you so much with the part B because I just wanted to deal with part A today. See if you could identify, 6 would be good, 6 possible pathologic causes of death in this patient. Okay? Give me a few minutes for that, and then I'll invite you to share in the chat in a little while. Okay, when you're ready, you can start sharing in the chat what your 6 possible causes are. Don't be shy. I want the 6. That's only one. I want 6. Just make a little list and put it in the chat, please.
Or do you want the full list?
Okay, we're getting some good suggestions so far. Can I get some other sharings, please? Okay. Remember, I need my list of 6. Anybody else weighing in? Okay. So we have quite a range of diagnoses here. Okay. So the important thing, young people, is that you'd have to approach something like this, which is a very, very general question. You'd have to have some sort of systematic approach to the question. I'm not even getting into part B at the moment, but just in terms of the part A. So the causes, certain in terms of sudden death, we are thinking it's important to think through the systems and for a given patient, what might be applicable to that patient. Because the scenario that I've presented you with is exactly what we could have received. Remember, I said to you that many times for the coroner's cases, the information can be relatively limited, and certainly compared to the hospital cases where oftentimes the patients have had an opportunity to be worked up, at least have certain preliminary investigations and so on. So we do need to think through in a systematic way what these potential causes could be. Um, and I do think it's important. Remember, I said that sudden natural causes would be one category that we would be thinking about. But remember the scenario in which he was found, okay, on the floor of the bathroom. So there is a possibility of trauma. I noticed someone mentioned in terms of manner of death, suicide. So that would be the manner of death, in which case perhaps you'd be thinking about something like it would fall into the category of poisoning with something like perhaps an overdose. Um, so yes, it's important to think wide and outside of the box. We must think about the natural causes, but the scenario would open itself to some other possibilities, including trauma, head trauma, whether it was accidental or not, and some form of overdose, again, whether accidental or in a form of suicide. Okay, so in terms of these sudden natural causes, we do need to think through what the different systems are. And if I look in the chat, I do think many of you spoke to the cardiovascular system, the central nervous system, and some specifics related to diabetes, which is good. So cardiovascular would be a very good place to start for this patient in terms of sudden death, because he does actually fit the profile, doesn't he? He's a middle-aged man. He does have a history of diabetes. So we do know that he has at least one major risk factor for atherosclerosis. And the coronary artery disease, of course, would be the basis for his ischemic heart disease, in this case, an acute myocardial infarction. So that would definitely, absolutely must be on the list as far as cardiovascular is concerned. I don't know if I saw anything else in the chat. Look back. If there somebody mentioned, I'm looking at other forms of heart disease. Somebody mentioned hypertrophic cardiomyopathy. This is not the usual profile, sort of demographic profile. And as you all know, we do need to rule out other causes before we come to the cardiomyopathies. Just to say that as far as the major forms of heart disease are concerned in middle-aged patients, the other major one, of course, is hypertension, hypertensive heart disease, which in and of itself can cause, of course, failure and death with or without superimposed ischemic heart disease, like we were talking about on Wednesday. So when it comes to diseases of the heart, in middle-aged patients, those are the two big entities to think about: ischemic heart disease and hypertensive heart disease. For the pediatric population, of course, we would also have to be thinking about congenital heart disease. And I know between Dr. Bishop and the pediatricians would have introduced you to some of these important congenital causes. Valvular causes, thankfully, in our era, are much less common. Things like rheumatic heart disease. We still occasionally see patients with infective endocarditis and other forms of valvular disease, but the global treatment and recognition and treatment of the risk factors for rheumatic heart disease, i.e. strep throat, have really brought down the incidence and occurrence of that form of heart disease. And then we do have the cardiomyopathies, but as I said, in this particular scenario, it would be much less likely. I'm happy that a few of you also, though, recognized that cardiovascular, of course, we have to think about the vessels, not just the heart, and the aorta. Aortic disease would be an important consideration here. I saw both of the major aortic diseases mentioned in the possible causes, that is aortic dissection and aortic aneurysm. We mentioned aortic aneurysm on Wednesday when we were talking about, hold on one sec for me, students, one sec. Very interesting, young doctors. I have a big sign on the door and they're still knocking down the door. Never mind. Sorry about that. Where was I? Aortic disease. We mentioned aortic aneurysm on Wednesday as a complication of atherosclerosis. And usually the aneurysm is occurring in the infrarenal portion of the aorta. And it's very important. The surgeons will teach you about monitoring patients with aortic aneurysm in terms of times to intervene in an elective manner to prevent the major complication, of course, which is rupture. Aortic dissection, both of them do have this risk factor of hypertension associated. But please remember, they are two completely different diseases. Aortic dissection follows a breach in the intima of the aorta, and that can occur anywhere, usually in the arch of the aorta or in the thoracic aorta. And this breach in the intima allows blood to access the wall of the aorta. You can get a double barrel aorta. And most importantly, of course, it can then rupture. It's a weakness within the aortic wall, and this can rupture either into pleural or peritoneal cavities, or even dissecting back into the pericardium. So as you go along and you're reviewing your cardiovascular, yes, you must be clear in your minds, have an opportunity, make sure you review the aortic aneurysm versus the aortic dissection, two separate diseases. And why I'm stressing it a little bit is because our studies here have shown that when it comes to sudden death in our patients, in our setting, aortic disease is a significant factor. Okay, so in the cardiovascular, some important things to mention for this patient would have been acute myocardial infarction, secondary to coronary artery disease, aortic, likely ruptured aortic aneurysm, or ruptured aortic dissection. Okay, so that is cardiovascular. And see, we have 3 big causes already. Then we went to most people, then the other major system that most people mentioned was the central nervous system. And that is appropriate because, again, in our setting, CNS disease from clinical stroke is in fact a fairly common phenomenon. So I saw persons mentioning ischemia and hemorrhage. Ischemia, certainly on the basis again of atherosclerosis, he is at risk. The hemorrhagic stroke, as we had discussed on Wednesday, more likely in the patients with coexisting hypertension. What else in the CNS? I saw somebody mention subarachnoid hemorrhage. So again, subarachnoid hemorrhage would be a feature, but that's not a cause. What I'd be interested in is, what do you think is causing the subarachnoid hemorrhage, Adebayo? What do you think is causing the subarachnoid hemorrhage, or anyone? I will take it, but I need to know what you think is underlying the subarachnoid hemorrhage. Anybody? Yeah. So what kind of aneurysm? We're just speaking about an aortic aneurysm, which is usually occurs on the basis of atherosclerosis. What kind of, okay, so the berry aneurysm, what kind of aneurysm is a berry aneurysm? So now we are in 4th year and we're doing senior stuff. We have to get the details right, okay? So an aortic aneurysm is an acquired aneurysm related, usually commonest predisposing factor is atherosclerosis. There are some others, but berry aneurysm, in contrast, is a congenital. Okay, so yes, a ruptured berry aneurysm, and usually it is associated with subarachnoid hemorrhage. And when we are doing that examination of the brain, remember, as I mentioned to you earlier this week, that the examination of the brain is a specific procedure in and of itself. And an important part of that, in a case, if we were suspecting like a berry aneurysm, a very important part of that is a very careful dissection of the circle of Willis. Can be quite time consuming because these aneurysms in fact can be quite small, often occurring at sites of bifurcation or branching. So that is a topic that again, you're meeting a lot of topics that you know that you need to review. But again, he actually does not quite fit the commonest demographic for berry, but I certainly will take it as a possibility. So in the central nervous system, we would say, infarcts, bleeds may be related to atherosclerosis, hypertension, ruptured aneurysm. And there is another important consideration for the CNS. And I did see somebody mention brain tumor, but remember that he didn't have any, he wasn't feeling unwell, he didn't have any major symptomatology. It's unusual for somebody dying from a brain tumor to just to actually succumb to sudden death without any sort of pre-death symptoms and so on. But there is another important consideration with the CNS. And remember earlier we mentioned trauma. We mentioned that he could have fallen. So head trauma would be a consideration in this patient. Okay, so you, of course, in A&E, they would make sure to examine. And of course, if there was an opportunity to do CTs or other findings or other investigations, we'll be looking to see if there's any evidence of trauma. I'm sure Dr. Jagan will review head trauma with you, but it's important to think about the different levels that could be affected in a traumatic episode. I don't understand what is happening. They all know that I'm teaching. So whether it's, there may be evidence of external trauma in the form of injury to the scalp. Then we may have skull fractures, we may have bleeds at different levels, involving the meninges, involving the brain, and so on. So we're not going to get into the details of it, but blunt head trauma is what I'm thinking about. From a fall could be a consideration here. Okay, so what we're doing, young people, as you can see, is that we're working through the systems. Yes, so we did cardiovascular, and we thought about CNS. So far, can you imagine, we have already finished the 6. So it may have sounded like a lot to you at the beginning, but in fact, I could easily have asked you 10 or 12 or 20 causes, right? And by the end of class today, you could reel them off. Wonderful. So let's move on to another system. As I said, the medical students I've watched this over the years. Medical students' favorite diagnosis is PE. And sure enough, I know it would be featuring on the list. There we go. Why am I throwing out your PE consideration in this patient? Didn't make it to my list. Why am I throwing it out? Why don't I like? Why do you love? Well, you love PE, but why don't I love it? Why wouldn't I put it on my list in this patient? Remember the scenario, young people. We don't have any history of him being unwell. We don't have any history of him, for example, having had some sort of medical procedure and being confined to bed. Because what you have to produce with PE is a risk factor. What would be his risk factor for developing a pulmonary embolus? People don't just jump up and get PE. Okay? We need a reasonable predisposing factor. Diabetes on its own is a risk factor for deep vein thrombosis, not to the best of my knowledge. Unless they're doing some new medicine these days. We're going to go into that in a little while, okay? When it comes to respiratory, in fact, yes, so I'm not saying PE isn't a cause of sudden death. Be careful. But what we want to do is we want to be able to identify what the risk factor in the patient would be. Okay? In the respiratory, there are actually not a lot of other major causes of sudden natural death, because many of the respiratory causes are going to, the patient is going to have symptoms and signs, especially whether it's the infections, the chronic obstructive lung disease, the tumors, all of these things in respiratory. So respiratory diseases are very significant. I mean, we're still in the COVID pandemic, but the reality is that with the respiratory causes, most of them are going to carry significant symptomatology and signs, them collapsing and dying. The sort of important one to remember is bronchial asthma. When I was at your stage, and I think patients in general were, well, there was less asthma medication generally available, including all the various inhalers and so on. And I think patients were less aware of how critical asthma can become, even within a matter of minutes to hours. Okay, so bronchial asthma is still a consideration in terms of um, sudden demise, but again, much less common in this day and age with what is available for asthma treatment. Other systems in general to young people, you're going to find that most of the other systems are not going to carry a lot of causes of true sudden natural death, whether it's in the GI tract, the GU tract. Many of these systems, again, it's not that patients don't die from these diseases, but usually they're going to find that they have history. So if we're thinking about things like causes of GI bleed, massive GI bleed, patients with peptic ulcer, patients with stomach tumors, patients with bowel tumors, patients with diverticular disease, and all of these other important causes usually are going to have a history. Yes, Adebel.
In the case of the bronchial asthma that you mentioned, would that then become more of a non-corona case, seeing as we have the history of bronchial asthma or something like that?
Yes, as it would for the other cases. My point is that it used to be an important cause of sudden death because patients would not access treatment on time for their bronchial asthma. So the major systems here for this particular patient and scenario would be the cardiovascular, central nervous system, and importantly, I did see, and I'm very happy about that you spoke about the complications of diabetes, the straight metabolic complications. So yes, the patient, we know that he was on medication, but we don't have any idea. Suppose he hadn't been taking the meds, suppose he took too much meds. So both the consideration of hyper or hypo glycemic coma are very important considerations, and absolutely those would be on my list. And then, as we had said earlier, we would want to think about, apart from sudden natural death, trauma, and whether there could have been any sort of something else is going on with this patient. For example, the wife doesn't even know there is a drug-related issue, something like that, where we would actually be thinking about poisoning and needing to do toxicology in a case like this. So those would be the really important considerations in a patient like this. We'd approach the case as such. So we would be prepared to be looking, excluding any evidence of trauma, going through our systems in terms of in a systematic way, as we have been speaking about all week. And as you go through the clerkship, you will see that there's a systematic approach to the autopsy. We would have been preparing, if we weren't finding major findings, to be taking off samples for toxicology, trying to get some more history from the relatives. Because when it comes to toxicology, it's really important to get as much information as we can. What were the medications the patient was taking? Was there any possibility that he was taking something outside of the prescribed medications? That sort of history is very important because it helps the forensic lab to be able to hone in on what are the metabolites they're actually needing to look for. Okay? So I gave you a little prelude. I told you to go home and do your homework was to go over thrombosis and embolism. Remember? Because this week You're supposed to be reviewing all of your basic pathology. That's semester 1. Those who haven't started, don't be dismayed. You have the whole weekend because you're not doing anything else apart from studying pathology this weekend. So you'll have an opportunity to, you need to finish. You need to go through all of the basic pathology lectures, and then you can get started on a system like cardiovascular because, I think every day this week we have spoken, atherosclerosis has come up, the big mama of them all. So yes, we have a lot of work to do. So we did our review of thrombosis, embolism. What is an embolus? I have my definition. What is yours? What is an embolus? See what's happening in the chat here. What is an embolus? I wonder if Kyle got that. So Kyle is the fastest one on Google. Just playing. I hope that you really know it, Kyle. So here is, so it's important to remember that, and yes, that's a good source. We can recommend that source for sure. Although the most important resource on that matter, young people, the most important resource for you over the next 9 weeks in this clerkship for anatomical are those lecture notes. I spoke about it on Monday. I'm going to say it again today, that you must find the lecture notes. We have done brilliant lectures from first semester. Every semester we have taught you, and fairly brilliantly, I will say, because we do have a tradition in pathology for teaching very well. And I know you got lecture notes for every single lecture. So that's what you need to find, okay? Why do I stress that? Because, of course, Robbins is the text, and it's very good to have your text. You can use it to, to consolidate your learning, see the pictures, charts, and all of that. But the lecture notes indicate to you what our emphasis is for you. And sometimes those are actually local influences. So things, for example, like diseases that are homegrown, things like sickle cell disease, the HTLV1 related diseases, so the lectures can help to guide you in terms of what the lecturers' sort of stressors are. So it's important to remember that when we're talking about embolism, it's not just thrombi, okay? It's any detached intravascular, solid, liquid, or gaseous material carried by the bloodstream to a site that is distant from its point of origin. So it is not just thrombus, it's different types of material, and it moves in the bloodstream to a distant site. So what kind of emboli can you tell me about then? So I know everybody knows about thrombosis. So we have thromboemboli, okay? So we could have fat, air, very good. So it's to remember that these emboli can take many different forms. Thrombus would be the most common one that we're going to meet and that you're going to meet in clinical practice. But these other forms are important, and to remember them when there are certain scenarios. So, I mean, the classic sort of fat embolism story is a patient who has suffered multi-trauma, something like a MVA with multiple fractures of the long bones, and after a few days, patient may not manifest any symptoms right away, but usually within a few days, within 2 to 3 days, they start developing respiratory distress. Sometimes they have central nervous system symptoms and signs related to these emboli. Some of the air and gas emboli related to the scenario in deep sea diving. We have the amniotic fluid as a part of pregnancy complications. Occasionally, atherosclerotic debris, tumor fragments, foreign bodies, all of these can actually detach into and move through the vascular system to a distant site and cause complications there. Okay, so it's important to remember that there are different types of emboli. When it comes to thrombosis, remember I was saying in our patient today that we're thinking about our middle-aged man who has collapsed suddenly. I was saying to you that I didn't like PE, pulmonary thromboembolism, as an important cause because we didn't have any evidence in the history that we had been given that there was a likely risk factor for him. And when it comes to thrombosis, we go back to our tried and true Virchow's triad. I hope this is ringing some bells for you. So what are the things that predispose to thrombosis? Endothelial injury, stasis, which is a major factor for patients in hospital, very ill patients who are immobile, and this is why antithrombus prophylaxis is important when you are managing these patients, because this does increase the risk factor, the risk for thrombosis. And then the hypercoagulable states, the hematologists are going to do a wonderful job of reviewing this with you. So what are all the different congenital and inherited conditions that cause hypercoagulable states for patients, including, can I put it in there? There are certain tumors that are associated with increased risk for thrombosis. So that raises the issue of paraneoplastic syndromes. For all who don't remember their paraneoplastic syndromes, all will be revealed when you review your basic neoplasia lectures. Enough said. So when we're thinking about thrombosis, we're thinking about what could be predisposing, what part of Virchow's triad may be involved in a given patient. Okay? And as you know, the most common site for these are the deep veins of the leg. Sometimes it's the pelvic veins as well, which we'll see, like, for example, women, even some of the women with very, very, massive uterine fibroids, and they can develop all sorts of relative obstruction in the vessels in that pelvis and are predisposed to stasis and thrombosis. But usually where we're looking is the deep veins of the leg, like the popliteal vein. So this will be the thrombi will dislodge, because remember, by definition, an embolus dislodges from its primary site and moves to another site. And the big problem, of course, in that case, is that it's moving to the lungs. And unfortunately, there are a number of complications for these pulmonary thromboemboli. I'm not sure if those who were in the autopsy room this week were there when the residents actually identified the pulmonary thromboemboli in our patient on Wednesday. But when we're examining these clots now, the important thing in our mind is to decide, is it a antemortem clot, or is it a true thrombus, or is it in fact a postmortem clot, something that has developed after death. And there are some important signs for us. The antemortem thrombus tends to be, and one of the key signs is it's usually relatively adherent to the vessel wall compared to postmortem clots, which are very easy to slide in and out of vessels. In the postmortem clot, we'll usually have some settling within the clot with the serum on top, producing this what we call a chicken fat appearance to the clot. For the antemortem thrombi, on the other hand, especially if they're large and we're seeing them in some of the main vessels, if you remember the different components of the thrombus, and that we can have fibrin and we have the platelets and so on, we can actually see lines. It looks like horizontal lines when we cut into the clot, and they're called lines of Zahn. So some of these are important features which can help us to be clear in our minds, is this antemortem thrombus or is it a postmortem clot? And certainly for the thromboemboli, and the major issue is obstruction. If we can have we can have obstruction, what we call saddle emboli, which actually saddle the pulmonary vessels and cause, in fact, sudden death, immediate respiratory arrest. We can have them much smaller thrombi, which can then go into the more peripheral areas of the lung, and certainly ours can be associated with infarction because we're having obstruction to the flow. Okay, so and wherever these emboli lodge, whether it's thrombi or other form of emboli, the major issue is that they will cause obstruction and of the area to which they embolize. Okay, so one of the things I wanted to mention in closing is that we do have to issue a report. I've spoken about this week, that we have different types of reports. We have the provisional reports. So I did in fact sign today the provisional report for the patient that we did on Wednesday, based on the gross findings, the findings of the PE, the findings of the heart disease, the atherosclerosis, and so on and so forth. So I've signed that. And in terms of other findings, I'm trying to remember with her. What did we have with her? I think there were some incidental findings. It's not coming to me clearly, but certainly for a middle-aged female patient, there are things like, I know she didn't have fibroids, that's pretty common. Gallstones, thyroid disease, all of these things are relatively common, incidental, or what we'd call other findings. I think I have another chart here, yes, to help you understand a little bit more. So whether we're talking about the provisional or the final, these are the three major areas of the report. The provisional, based on the gross findings, and remember that the final diagnosis is based on complete examination. So I can only issue the final after we have examined the brain properly, we've examined all the slides related to the case, reviewed any microbe investigations, were there any other investigations to review before we can actually issue a final. We have the first category of the report is findings related to principal disease. So in the patient on Wednesday and our discussion today, what is a major disease that affected this patient? So, we talk about things like the hypertension, the diabetes predisposing to atherosclerosis. So the predisposing factors, the principal disease itself, the complications. So it was coronary artery disease complicated by acute MI, and whether there are any treatment-related findings. All of that is part of our report. So it's a very comprehensive report when it comes to, somebody spoke on Wednesday about connecting the dots and making it make sense what has been happening to this patient and how we have reached to this point where unfortunately they have died. The other findings related to the patient demographics, as I said, for the women, common things that we see as incidental findings: fibroids, gallstones, thyroid disease. In the men, what would be, let's make him a little older. Let's make him 65 or 70. What would be a common incidental finding in an older male patient? something that we see all the time in a male patient. Prostatic disease, that's right. So remember, if it's incidental, it's more likely to be nodular hyperplasia. And I did say incidental because nodular hyperplasia and prostate disease, of course, could be the principal disease and cause things like obstructive uropathy and sepsis and all sorts of interesting things. But prostate disease is very common in our population. So it is important. It's going to be on your list to review. Prostate disease, both nodular hyperplasia and prostate cancer. Prostate cancer runs a spectrum from, yes, we can discover it incidentally, to disease, of course, as you know, that is very aggressive. And the patients, it metastasizes to the bones all over the place, and the patients die from, of course, patients die from prostatic cancer. The last part of the report is a clinical pathologic summary. So today, when I signed the case today, my summary ended with the fact that we have reminding the clinicians that we have not yet looked at the brain. So we will issue the findings of the brain when we have had a chance to examine that, and that will be part of the final. Okay, but it's a little summary that the pathologist writes. It's usually just a few sentences which say, okay, these are our findings, and yes, there is agreement with the clinical assessment. It's very important for us where there is not agreement. So, for example, the case came and they were suspecting MI, but we didn't find MI. We did find PE. So in the summary, we would say something like, there was no evidence of myocardial infarction in this patient. However, the finding of a saddle thromboembolus correlates with the patient's history of acute chest pain, something like that. So we basically try to really wrap up the case and bring in our clinical pathologic correlation so that the case makes sense for everybody, and especially the clinicians who then have the responsibility. This goes back to the ward, back to A&E, back to the clinical doctors in charge, so that they can then use this as a basis to complete the patient's death certificate. As you know, that's very important, and it must take place to allow the registration of the death before, in fact, patients' bodies can be released for burial and that sort of thing. Okay, and as I had shared earlier, the provisional or findings, for example, what I signed today, will be more than sufficient for the doctors to write the death certificate. So usually that process of the registration and the death certificate does not need to wait on the final, unless it's a case where we go in and we really don't find anything, we're worried about toxicology, in which case, yes, we do actually have to hold, and the body cannot be disposed of until we are clear that we have taken the samples, we have actually sent them off, we have received a report as to what could be going on with this patient. Okay, folks. Any questions from what I have shared today? I have been kind of teasing you this week, kind of teasing you today, but it's actually, I'm not joking when it comes to the fact that you don't have a Labor Day weekend and that you have a whole heap of work to do. Yes, you can take a breather, and perhaps you have a little Labor Day project, but may I suggest strongly that the most important Labor Day project you have to do is to study your pathology. Whatever you're doing, young people, stay safe and well. We are in the midst of the 5th wave, and you all need to stay safe and well. All right. So take good care.